Hi, I'm Dr. Grant. I'm a 40-something-year-old physician wearing a white coat.
Hi, I'm Dr. Woodward. I'm a female with red hair wearing a white coat.
So, is it Alzheimer's disease or is it dementia is probably one of the most common questions that I get regularly in the clinic. And I think historically there's been a lot of misunderstanding of these terms, and they sometimes get used interchangeably, which is not exactly correct. If you go back a couple of decades, someone being told they had Alzheimer's disease was really just based on their symptoms and the probability that that's what was going on in their brain. But now we have other resources that can tell us for sure what the cause of a particular syndrome is. And so the term dementia is just a very general term that describes the symptoms. It just means that a person has had some kind of progressive decline in their cognition, usually their memory, that's made it so that they need some sort of assistance with stuff they didn't used to need help with. So driving, managing finances, keeping track of appointments, medications, those sorts of things. Once a person needs help with that, we call it a dementia. And the most common cause of dementia is Alzheimer's disease. And so Alzheimer's disease, when I use that term with patients, is really just to describe the actual physical disease in the brain. It's this accumulation of microscopic abnormal proteins that kind of clump together inside of and around brain cells and gradually damage them. The memory centers of the brain are generally the most susceptible to these changes. That's why most people who have Alzheimer's disease tend to be forgetful. So the way that I explain it to patients is that you may have dementia due to underlying Alzheimer's disease. It's really a cause and effect relationship. So people who've had a family member with Alzheimer's disease will oftentimes ask whether or not they're at risk and whether or not it's something that they can inherit. And there are a few forms of relatively rare, truly genetic diseases that cause Alzheimer's disease. These are specific mutations that can be passed down in a family, but it accounts for less than 1% of all cases of Alzheimer's disease, and it generally affects people very young. So there's a very clear family history of about 50% of one side of a person's family will all develop Alzheimer's disease quite young, oftentimes in their 40s. So the vast majority of cases are not that way, but many people will see that they have multiple family members who have this disease. And that's because there are many different what we think of as genetic risk factors that may be passed down. Some genes just confer a very small amount of risk. There's one gene in particular called APOE, which everyone carries and has 2 copies of. And a certain form of that gene, whether you have 1 or 2 copies, can more significantly increase the risk. So people who have a very strong family history of kind of typical older onset Alzheimer's disease, it's not unusual to find people who carry 1 or 2 copies of this gene.
So if a patient is having concerns about their memory, they can generally start by seeing their primary care provider, who can do some screening in the office. If they need additional testing or they have atypical symptoms, then they can see a specialist. And this can be a neurologist who can take care of the many different types of dementia, screen for it, test for it, and treat it. Or they can see a geriatrician who can also screen for and test for and treat dementias, but can also take care of other aspects of aging. Being a caregiver for someone with dementia can be extremely challenging and can often impact the caregiver's health. So it's really important that they take care of themselves. And some of the ways that I recommend this is making sure that they have a primary care provider that they can talk with. Support groups are really important. So we have support groups here through Northwestern. You can also find them online through the Alzheimer's Association. I also encourage all of my caregivers to read the 36-Hour Day. It is a fantastic book and resource for caregivers that I say, if you're having an issue or a challenge that comes up, that's an incredible resource. So making sure there's lots of different things you can be involved with. The other option I really like is the local area agency on aging. They have a lot of good resources for caregivers as well.
So there does seem to be some difference in risk as far as different racial and ethnic categories go. We know that Black Americans and Latino Latinx Americans also have a slightly higher risk. Asian Americans slightly lower. Of course, it's always important never to make generalizations in these areas, but it's likely that there are different factors that contribute, including socioeconomic ones and other disparities that are just common across all aspects of health that influence this risk. But it's really important that we learn more about this. And as a researcher, it's been a problem for a long time that many people who enroll into research tend to be white, and so the sample is not very representative. So we're doing everything we can to try to really increase representation from all these groups.
So there are going to be virtual care options for patients with dementia at Northwestern. We're in the process of setting up a program now, and it should be available in the late fall of 2024.
So the treatment of Alzheimer's disease is very multifaceted and definitely always centers around just managing the symptoms and supporting the patient and caregivers with whatever symptoms they may be dealing with. But there are also medical interventions. There are medications that have been around for quite a long time that are modestly effective at gradually slowing down the progression of memory symptoms over time. With respect specifically to Alzheimer's disease, there are now some newer medications that do attack the underlying disease in the brain. Again, it's a relatively modest change, just a slight slowing of the progression of disease, but it is an exciting time with more treatments probably on the horizon over the next decade.
What we're learning about Alzheimer's disease is that the changes in the brain start in midlife. So this is really the time to try to decrease your risk. So focusing on physical activity, a heart-healthy diet, especially the Mediterranean diet, has been shown to decrease the risk. Additionally, you want to reduce any risk factors you have for vascular disease. So making sure if you have diabetes, it's well controlled. If you have high blood pressure, it's well controlled. And if you have any history of high cholesterol, that you're on medications for that as well. And then things like cognitive stimulation, taking classes, learning a new skill, those things can be really important as well. Additionally, sleep can increase the risk, so making sure you're sleeping adequately is very important.
So although it's very frustrating that we still don't have a true cure for Alzheimer's disease, it is an exciting time right now that there seems to be a lot more momentum in the research space to develop treatments that actually go after the underlying disease. Over the past 20 years or so, there had basically been nothing but failed trial after failed trial, and it had been about 20 years since the last time the FDA approved a new treatment for Alzheimer's disease. So although the newest things are not cures by any means, they are moving the needle in the right direction, and I think it's sparking a lot more interest, especially from the pharmaceutical company side of things, as well as just general research funding to do more and more, and getting more people involved and interested in research is definitely something that I think shows a lot of promise for the next decade.
Unfortunately, there are not any known cases where it has been reversed. It's a disease that gets worse over time. We are hopeful with new advances in research we'll be able to slow down the process or eventually one day have a cure.
So there's pretty good evidence to show that repeated head trauma does increase the risk of dementia, including from Alzheimer's disease. There is also another cause of dementia called chronic traumatic encephalopathy, also known as CTE, which has been something that's been in news reports a lot over the past couple decades, where people who've played professional football, hockey, boxers, that sort of thing, develop dementia with a slightly different pathology in the brain, but basically we know that repeated head injuries are not good for you.
So I get asked very frequently, what's the difference between normal aging and dementia or Alzheimer's? And normal aging, as we get older, patients do become a little bit more forgetful, processing speeds slow down, things take a little bit longer. I like to say it's the tip of the tongue phenomenon. You walk into a room and you forget what you went in there for. Maybe you're watching a movie, you can't come up with the actor's name. Those are all normal aging changes. When your memory symptoms become more severe, you can't learn new information, or your memory symptoms are so severe they start to impact your day-to-day activities. You get lost driving, or you forget to take your medications, you mismanage your finances, and eventually have trouble dressing, bathing, and using the toilet. That's when we get worried that something else besides just normal aging is going on with your memory.
So it's very common when patients come to our clinic that when I ask the patient themselves, how's your memory? Do you have any concerns about your memory? They'll oftentimes say, oh, my memory's fine. Like my daughter brought me here. I don't know why I'm here. And the family member may say, oh, you're in denial. You have these memory problems. Why don't you understand that? And it's really important to explain to families that it's not really denial, because denial implies that the person has the ability to recognize these problems. And it's part of the underlying dementia process that the person experiencing the symptoms usually is not able to be aware of those symptoms. And to some degree, it kind of makes sense. You're not going to remember what you don't remember. And so it's very common that there can be some tension and frustration between family members because of this lack of understanding.
So I think it's really important for family members who are dealing with patients with Alzheimer's disease that they're there for their patient, they're supportive, they help focus on quality of life, and making sure the patient's safe. So ensuring if they're still living by themselves, they're not at risk for setting the house on fire or wondering that somebody's helping with their medications, their finances, and then kind of assessing if they're still safe to be driving or not. And that's certainly something that your provider can help with as well.
Yeah, and I know it can sometimes feel from the family member's perspective like there may be intruding upon a person's independence or their privacy to help out, but it is really important to make sure that there's some sort of safety nets in place to help prevent little slips in a person's management of their affairs to snowball into much bigger problems. Mm-hmm.